Great, thank you. Well, just to go over the agenda a little bit here, we're going to give the obligatory About Rush slide, and then kind of go into how we got to where we're at, to kind of the analysis of where we were and where we wanted to go, the approach that we took, and some of our outcomes, and then looking forward to say, where are we going to go from here, and then some of our recommendations, and then we'll open up at the end of the presentation for some Q&A from our listeners here. So a little bit about Rush. Rush University Medical Center is a little over 650 beds. We're an academic medical center. We have about 335,000 admissions per year, 65,000 ED visits per year, about 1,500 nursing staff, a little over 800 attending physicians, and just under 650 residents and fellows. We are currently on Epic 2017. We're upgrading to Epic 2018 in about a month, but originally went up on Epic in 2007. So prior to this initiative, we really took a look at our Epic build. When I arrived here, I really found that we had some fairly outdated documentation templates. We weren't using any voice-to-text technologies. In fact, when we went live on Epic in 2007, we took away dictation, and actually really our physicians were left with just either using copy and paste to copy previous notes forward or typing into Epic. We had no voice activation other than post-op notes for our surgeons. And so we really had fairly inefficient workflows for our providers. There were no specialty-specific workflows, and the note templates were fairly outdated. And even though we'd introduced some newer technologies and newer functionality from Epic, we really didn't have any ongoing training and optimization for our providers. In fact, when I arrived here, our training staff for all of Epic was at 5 trainers. And so they were really basically able to just cover new user training. There was no really ongoing touches with providers on training on new functionality. So we did a little further analysis, and that helped us make the case to our senior leadership that we needed to introduce some new technologies to help providers with their with the EHR, specifically with documentation. And we also looked at how we could increase our training and support staff going forward. So one of the things that we did that helped a lot was we joined the Class Arch Collaborative early on in its infancy, and last July sent the Class Arch Collaborative survey out to our providers. And it was very interesting. The number one thing that our providers came back and said to us in the comments was that they wanted more training. And when do providers ever ask for more training? But that spoke loud and clear to our leadership to say we needed to do something around the training. And then there was also we really didn't score very high in the efficiency scores in the Arch Collaborative either. And when we looked at our PEP and Signal data, we really saw that our biggest opportunity was in documentation. And that was really no surprise to us, but that helps us to really cement on where do we go for improving our provider efficiency with Epic. We also noted there was another initiative that was ongoing at the same time looking at why our case mix index was lower than expected. When we did in many areas, even though we're a tertiary and quaternary referral center, our case mix index was sometimes even lower than an average community hospital. And when the analysis was done, it was again spoke loud and clear that documentation was the issue. Providers just weren't documenting to the level that was needed to capture what we needed for to represent to accurately represent our case mix index, and therefore we were looking lower than what we actually were. So this was also another big push to really help us get the funding we needed to get Dragon up and running, markedly revamp our documentation tools, and hire additional training staff for both the initial and ongoing training of our providers. So obviously then when we looked at, okay, what do we want to get out of this program, we identified some key performance indicators, and one of the number one was decreasing time in documentation. When we looked at the amount of time our providers were spending in the documentation activity, it was almost double the Epic average. We were at about 7 minutes in the notes activity per patient visit, and the Epic average was just over 4 minutes. We also noticed that our note length was significantly longer. Our note length was at about 8,000 characters, and the Epic average was about 3,500 characters. So we knew we had some significant opportunity here to decrease both the time in documentation and the length of our notes. We also noted that there was a significant amount of time when physicians were spending time after hours. It was primarily in the documentation activity, and we know that is the time spent after hours in the EHR is one of the big contributors to physician burnout. They're not going home. When they go home, they're not spending as much time with their family as they would love to, and they're spending time with the EHR. We saw these spikes between 8 and 10 p.m. Where physicians were logging back into Epic and finishing their documentation. Obviously, we knew we also wanted to improve our case mix index. Another thing we thought we could improve, and you'll see in our results that we're starting to see some movement there, was to decrease the retrospective clinical documentation improvement queries from our CDI nurses. We realized that if we can improve our upfront documentation so that providers are documenting what they need to do right up front and not getting these queries a day or so after and having to go back into a note and update that note, that we'd improve our provider satisfaction as well. And so overall, we're looking at reducing physician burnout in general. So we're using as I mentioned, we're using the Class Arch Collaborative survey to get some initial data. We also just completed the Stanford survey on physician burnout. We don't have the results back yet on that, but we don't suspect that we're any better than any other organization, so we expect to see our burnout rates in the mid 50% rate. But we're hoping to improve that with some of this initiative. So we'll be looking back at that Stanford survey and redoing that survey after this initiative's done. One of the other things that we looked at was, okay, this is a pretty big initiative, and we didn't have the training staff on site to be able to do this. We also had a fairly small analyst team. It was undersized, and we knew that we needed help with design and build of the documentation template. So when we reached out, we knew we were going with Nuance for Dragon. We reached out to Nuance for their optimization services, had them come in and do an evaluation, and then brought on some additional analysts and training and support staff to do both the design and build of our new documentation templates, but also to do some of the initial training and follow-up one-on-one training with providers to do that optimization work. And as Jordan's sitting here with me, one of the first things I did about a year and a half ago was really start to build an associate CMIO program. All the associate CMIOs went through the physician builder class, and we were brought on part-time. They all still have clinical duties, but they're all brought on part-time here in IS to help really improve physician workflows is the number one goal of the team. And so I brought on a broad spectrum of providers, both from our hospitalist service, a surgeon, emergency medicine, primary care, and pediatrics was our initial kind of areas of focus to get some of the main workflows of our providers and be able to give some direct feedback to our analysts and our build teams on how to improve physician workflows and decrease the burden of the EHR on our providers. So again, at the start of the initiative, really worked with Dragon. We're using the cloud-based Dragon Medical One and building that into our new, designing that into our new documentation templates. So I'm going to have Jordan kind of walk through our approach and some of our outcomes, and then we'll walk through, we'll finish out with kind of where we're going from here.
Great, thanks, Brian. As we highlighted here, our initial rollout for these optimizations were focused in the areas that we had associate CMIOs aligned. So as Brian just alluded to, we have associate CMIOs in emergency medicine. I'm one of the hospitalists that represents that group, and then we have primary care and general surgery represented. So we thought that was a great mixture of different documentation workflows that we could kind of trial some of these optimization efforts with. We also noticed we used the PEP and signal data in conjunction with class, but we also then ran some reports to see how many system templates we had created back when we went live with Epic, and we had over 400 templates that we considered kind of standard templates or standard documentation. But we actually recognized that only 10% of our users actually use those standard templates. So for me, that was a big signal for a call to kind of revamp that, really relook at why we've created so many different templates that we need to maintain and simplify that, both for our build teams and our IT resources, but also for clinicians. I think they're as confused by multiple different options as we are in terms of maintenance. So that was an initial kind of push just to clean out and simplify the documentation standards that we're using. And analysis of those templates also revealed that a lot of it was based on paper-based, documentation prior to the EHR that we just kind of shifted to a digital format, not really a reset for the EHR era. So a lot of it was, kind of a fill-in, a form and things of that nature, fill in your HPI, not using some of the most advanced tools that Epic and other vendors may be able to offer. And as Brian alluded to, voice to text, things like that, our templates weren't set up for that. So we really focused on modifying our templates, to simplify, but also to prepare those templates to use some of those newest features. And in the bottom left, it highlights, we wanted to embed some scoring systems that, a clinician would have to remember what the scoring system's called, go out to our clinical resources or different areas, find that calculator, calculate it, then copy and paste that into a note. We've now embedded that into all of our documentation. So if you fill out the form and you put the right marker within your template, once you complete filling out that scoring system, it just populates into your note with the aligned recommendation. So one, I work in our perioperative clinic. We do a lot of revised cardiac risk index score stratification. Now we just have a form that you fill that out, very simple. It gives you the percent risk for cardiac risk per procedure, and then that's automatically dropped in my note. So I just have to click 5 buttons, it's finished, and it goes into my notes. So we try to streamline that with smart forms and smart documentation. We also approach problem-oriented charting, which we've started to use in the hospitalist group and in a few of the primary care clinics as well, more to help with that documentation of chronic comorbidities and to really have that impact on case mix index. I think, if we look in 30 to 60% of diagnoses probably in our primary care cohort are chronic conditions, it was thought that that would really relieve some of that burden of redocumenting that condition every visit, whether it's inpatient or in the ambulatory setting. I also touched already on risk scores. There were other scores that we also built into smart forms. And then we also wanted to start shifting towards preparing our templates to use patient-entered data using questionnaires. We've started using that for new patients, but specifically in our pediatric clinic, they use a lot of questionnaires that they have patients' parents fill out. And then either actually in that clinic, it was usually the physician that was then scribing that into their note. And then it was really hard to track that data, really hard to reuse that from encounter to encounter. So we've tried to prepare with some customization, building those into forms that can be translated across multiple visits. On the right side, I think I touched on the top part, standardization, but documentation quality was also important. As Brian alluded to, we had an issue with note bloat, really long notes that people had no awareness, self-awareness to, and this was really what was, I think, impacting some of our CDI queries and our inability to increase our CMI appropriately because they were wasting their time on inefficient documentation. So now we can kind of redirect them on some of these quality measures. And then the final part in this slide is just we really needed to make sure we had additional training resources to make sure, documentation for providers is really personal. And so we wanted to make sure somebody was at the elbow providing that one-on-one optimization training to kind of have the conversation of why we were going through this program and help them understand why we needed to change out certain parts of their note template that they've used for 5 years, that to them, they may not have had a self-awareness that it was a problem, but just educating them on the kind of culture shift and what we're trying to address.
Yeah, and I just want to comment on this, on the one-on-one optimization training. Nuance has been a great partner in this, and they've really helped develop the skills of our new team that we brought on here. And so they've been doing, initially did a lot of the one-on-one optimization training for our providers, but are also doing a lot of knowledge transfer to our new training resources that we're bringing on board so that we can take this and run with it and continue on once our Nuance optimization services are no longer on the ground, our team can take it and run with it. And so that's been a great collaborative effort in getting that one-on-one training, that optimization, provider by provider optimization in the EHR. It's been a very good experience.
Yeah, and although they've focused on documentation with most of their sessions, they're touching on all personalization and kind of efficiency tips. So it's been great to just hear other physicians excited about something that maybe we've had, within Epic for 3 years, that somebody finally showed them, all the workflow and the steps and the benefit that they may not have realized. That light bulb may have not gone on unless we had that one-on-one optimization training resource and team. So this just speaks to that training. As Brian alluded to in our class survey, providers were asking for more training. There really was a kind of a lack of engagement because we didn't have that continuous training model. We had onboard training, and then if they were here for 10 years, they were kind of given refreshers with upgrade content, but there was no kind of continuous education or optimization. And when we started this with the Nuance team, this is some of the feedback we got from our providers, which was resoundingly positive. I've had individuals email me and say, finally, I can get back to my family and have dinner with them on time. I'm closing all my charts at the end of my shift for the ED, and I'm getting home, which usually they just stay an extra hour or two more to do that. So it's really added a huge benefit in terms of well-being, and I think engagement for our physicians and our APPs that have utilized this resource. And so there's a quote at the bottom just about how so many of the new techniques to make my note writing and use of Epic for chart review more efficient was really helpful. And that's really the resounding message. I've been shocked at how many physicians have remembered their trainer's name, and when they usually email me, giving positive feedback, they say, trainer, number one was fabulous, and they showed me XYZ. Usually we don't get that type of detailed feedback in IT.
Yeah, we're just getting so much positive feedback from our providers on just how valuable this, especially the one-on-one optimization training, has been for them to really improve their efficiency. We just got literally a page and a half letter from a provider the other day, just going through in detail how this has really changed her life, and she's just was profusely thanking the training team, again naming names, and it was just it was very positive affirmation. We passed that one obviously on up to senior leadership to say, hey, this is the impact. You know, you invested in this program, and here's the impact that it's having on our providers.
So some of the early results from our optimization are establishing that long-term support and training model for physicians by specialty. So as Brian and I have kind of alluded to, we've really relied on Nuance to do the initial one-on-one training while we've stood up kind of additional trainers within our IT shop here. And they've been able to get that knowledge transfer and expertise from the Nuance trainers and carry that forward. It's also really helped us prove to senior leadership that this is a resource we need to continue to cultivate and grow. And we've been able to align those new trainers as they come on with a certain specialty. So if they're, they know the surgical workflows, they work with the surgeons versus inpatient, ambulatory, and so that we can really do those deep dives on some of the personalization and optimization features. I think even just starting to have these conversations around documentation that I alluded to, people take very personally, has engaged a new group of physicians and other providers across our organization. We kind of started that engagement with the surveys, with the class survey and the burnout survey, and informing people that we were going to kind of, use that as a call to action. But just starting this optimization and actually getting those one-on-one sessions, I think people realize that we're actually, really taking a lot of those survey results to heart, taking those to senior leadership, taking those results personally, and that's really added a lot of new engagement across our physicians. And that's really changed the culture and conversation around documentation. I don't think there was much of one prior to kicking this off. It was, this is how somebody showed me how to do it day one. I'm able to close my charts, get home at a reasonable hour, even though I have to reopen Epic to finish everything after I put the kids to bed. But they thought that was normal. And there was a lack of self-awareness of some of those habits and behaviors. And this optimization effort has really changed that. There's a lot of conversation about, should I be using certain smart links to, bring in all of this, full CT read or things of that nature, when in reality I'm only making my clinical decision on one piece of that read. And really trying to consciously think about how we can tackle note bloat. I think we can do some work on the IT side to stop propagating that behavior, but it also needs to be a culture and a conversation to really decrease those habits. So we also focused on making sure that our physicians and EVPs could practice at the top of their licensure, and give more engagement, give them a voice as well. We also used, we really collaborated with our coding compliance department to do these revamps of the templates. So the other thing is that a physician doesn't have to think about what the coding regulation or compliance rules are. We've kind of embedded that into our best standard, and that's what we're resetting all of their practices with the one-on-one training. There's been a lot of sense of relief of, okay, I'm not going to get a call later on that I was non-compliant or not, up to a coding regulation. So we kind of embedded that grunt work into this process.
Yeah, so we're still in the midst of a lot of the training. We're about halfway through training our about 800 providers is our target to really hit every provider. We haven't made this mandatory, but right now, as the provider group's going through, we're seeing about 80 to 90% of our providers taking advantage of the training and optimization as we go through each provider group. We're looking at, so how are we going to evaluate this? We're obviously going to redo the Class Arch Collaborative survey in the July or August timeframe and see if we've moved the needle. We'll be also redoing the Stanford survey sometime early next year to follow up on the survey that we just completed. Again, to see, our expectation is that we'll move the needle on physician burnout and on physicians, self-evaluation of their efficiency in using Epic. And so hopefully those surveys will bear that out. We're also continuing to track our key performance indicators that we mentioned earlier. Early on, we're using the PEP and signal reports from Epic. We're going back and looking at, okay, here's a provider group that's now been through training. What's their utilization of Dragon? And are we seeing some, and we're already seeing some downward trends in both time spent in note and note length. And so that's been some good early validation of some of the work that we're doing. We're continuing to build out a template for other specialties. As Jordan mentioned, we started with our specialties where we had our associate CMIOs, and so hospitalist and internal medicine, general surgery, emergency medicine, primary care, and pediatrics. And we're now moving into some of the other specialties and developing. The other side effect of this is we're developing a sense of who some good physician super users are going to be for those communities, and so and looking to get some of those physician super users in each of the specialties and get them some additional training on Epic, get them up for physician builder training, have them go through the physician power user courses. And really have a cadre of physician super users out there that can give us feedback from each specialty on improvements that they'd like to see in our build of Epic.
And I think that's been surprising for us. I mean, just in terms of that engagement, how we've gotten those physician champions to just kind of start volunteering and forming a line. I mean, we had a transplant surgeon that said, I want this, I want all the tools kind of baked in because, they heard this was happening and there's a shift. And so it's really helped us to quickly identify those physician champions, and they're coming, they want to be a part of this process. It's part of their day, every day when they're taking care of patients. So they're really self-motivated to help this be a success for other specialties. Yeah,
we just had a vascular surgeon come to us today to say, hey, how can I get more involved? I'm seeing the impact. And wanting to get more involved in continuing the optimization work that we've already started.
I think it's also shifted the conversation around some of the PEP data. I know, probably many are familiar that it's somewhat cumbersome on how you can share that data with medical directors or other individuals just because of how it's distributed. But there's been a lot of conversation from senior leadership and medical directors of why can't we just show this to everybody, get people more self-aware of their habits within the EHR, and that's specific to documentation, but everything else that we do. Whereas before it was how do we share this and kind of digest this in a better way. But I think it's because we've layered on that support of one-on-one training and at the elbow support that people are more comfortable kind of putting that out there and using that as an opportunity to make sure people are using the system efficiently.
Mm-hmm. And while we haven't finished the data analysis, I know anecdotally we're in talking to providers, and Jordan has some good experience on this, and just decreasing our CDI queries.
Yeah, so I'm a hospitalist. I practice quite often in the inpatient space, and so I've used all of our new templates. And I would say, prior to this, I would get a CDI query, maybe one or two every day, just adding a comorbidity or something of that nature. And when I was on service for 2 weeks in a time, not too long ago, I only got one or two queries for that whole 2-week period. And so, of course, I was fully embedded in using every single tool, problem-oriented charting, and some of the other documentation features that we're not even detailing here. But just for me, seeing that decrease in kind of those delayed documentation requests that I have to go back and find a chart from 3+ days ago and remember, my state of mind, the patient's state of mind, and then document all of that to appease that query. The fact that I didn't have as many of those from my well-being, and the fact that I was able to get off service and didn't have a bunch to follow up on was a huge positive.
Yes, I mean, just in general, just the mood of our providers, you can just sense the change out there when we go to provider meetings. It's much more highly engaged. Just in the really only 3 months that we've been involved in this project, we're really seeing our provider engagement improve. So I think keys to success. Some of it was really pretty obvious. We knew that we weren't training our providers, and we weren't giving them the best tools, or even if we built the tools, we hadn't been doing the ongoing training and really one-on-one support of making sure that our providers understood the benefits of some of the stuff that we told them we were rolling out, but we hadn't really done the deep dive on training. And so, having the Nuance team come in and really do a deep dive with our providers, not only just training Dragon, but really doing that one-on-one optimization support, showing physicians all of these new tools and making sure that they're utilizing them and optimizing their workflows and making sure that our providers are using our EHR to the best of its advantage. It's just that's been absolutely huge. Our associate CMIO team has just been great, being able to have access physicians that our analysts have access to on a day-to-day basis to get feedback on the workflows that they're designing and on content that they're planning on rolling out. And having that feedback from our associate CMIO team has been great. It was interesting when we got the class survey data back. I was going over the ARCH Collaborative results with Taylor Davis from class, and I said, we went on this one slide where providers by specialty rated their efficiency within Epic, and there was 5 areas where we stood out. The rest of it we were kind of right on the average, but there were 5 areas where there was a movement. And interesting, each of those 5 areas is where we had one of our associate CMIOs. And so, in pediatrics, in internal medicine, emergency department, general surgery, we noticed that those were the areas where we had some movement. So that also validated the value of our associate CMIO program and getting physicians trained in the physician builder class, but then getting them much more involved with our analyst team right up front.
And I think one thing that we haven't highlighted too much in this talk, but we touched base early on, is we didn't have a voice-to-text solution that was enterprise-wide starting this. So this was also integrated with our rollout or integration of Dragon Medical One. And I've kind of recognized, and I know I've told lots of people at Nuance that was kind of utilized as kind of a gateway efficiency tool for a lot of our providers. So it got them to be more self-aware of all the efficiency opportunities that they may be missing. And then we kind of back that up with the Nuance optimization services to do the one-on-one training to make sure that they were addressing other inefficiencies in the system. And this documentation initiative was kind of all embedded in that workflow. And I think I alluded to the one that's really comforted a lot of physicians when we've said, okay, we're going to blow up all your templates and kind of reset things, is that, we've assured them that we've gotten these templates approved by our coding compliance folks, so that's all embedded within that content, and it gives them, it takes that guesswork out of that documentation, so they don't have to stress over that part. They're already stressed about trying to get through their clinic day and provide appropriate care for their patients. We wanted to take that off their mind and not make that a barrier for their day.
And then just bringing on board a dedicated team for providers to continue this ongoing one-on-one support for providers. I had developed this at my previous organization at Health East, where we had a team of provider trainers who were focused on both the initial training of providers, but then the ongoing one-on-one support of providers out in the field. So when they had questions, basically anytime a help desk call came in from a provider, it got routed straight to that team. And so we're developing that team here, where provider help desk calls go straight to a specialist in provider tools and workflows. And if need be, they can log into that provider's computer or go and meet that provider out on the floor one-on-one and help them real time and get them back to caring for patients and not having to deal with issues or log a help desk ticket or things like that. That this team has really kind of taken that burden off of them and really both reactively and proactively getting out and doing additional training for providers. So when providers ask for it, they're doing it, but they're also evaluating the PEP scores and PEP reports and keeping their ear to the ground on who's having trouble and getting out there and proactively meeting with providers to give them some additional tips and workflow enhancements.